Thank you, Madam Chair. It's my great pleasure to share some of the preliminary findings from the OECD analysis on the systems of cancer care with you. It took 3 years to complete this study, and 38 member and non-member countries participated with the aim of comparing the relationship between the key dimensions of the cancer care and the survival outcome for breast, cervical, colorectal, and lung cancers.
Vladimir, can I just interrupt you there? Because I can't.
Sure.
Am I the only one who can't hear?
Okay.
No, people can you shout?
Fine, will do. Thanks. So why it's important to study cancer care policy? Firstly, the fight against the cancer have implications for the rest of the health system. And it's very important for the policymakers, actually, to use the existing resources in the most effective way and to learn which governance characteristics result in the best quality of care and related healthcare outcomes. We all know that there are considerable differences in the cancer survival rates across the countries. This slide shows 5-year relative cancer survival rates across the OECD countries, and the difference between the country with the lowest and the highest cancer survival rate is really huge, more than 30%. We know that European countries are lagging behind the United States. We know that there is a West-East European gap. We also know that some countries like United Kingdom and Denmark are trailing behind the similar countries. So why has it been happening? This study has tried to provide some answers. And the study was separated in 2 different parts. The first phase involved the development of the conceptual framework models and the macro level analysis that was undertaken by using the readily available data. This is how the conceptual framework model looks like. We joined the main domains of the cancer care into 3 distinguished broad groups, and these are the process quality, governance, and resources. All phases of the continuum of cancer care have been investigated apart from the prevention and palliative and end-of-life care. The first one was considered being too complex to be analyzed in a meaningful, internationally comparable way, and the palliative care has very little impact on survival outcome. The second phase of study has multiple goals. As I said, to explore the characteristics of systems of cancer care and to assess the relative effect of the main domains of the system of care, in particular governance and the organization of the cancer care for 4 major cancer sites. These are the countries that participated in the study, and you'll probably notice that the majority of these are European countries, but also we had the countries like Australia, New Zealand, Japan, Korea, Singapore, Canada, United States, Chile, who participated in the study by nominating their policy and data experts. We have been really dealing with the top experts, which were mostly the senior ministries official or directors of the national cancer registries. Apart from that, the OECD entered into the collaborative agreement with key players in the area of cancer. We had the great pleasure and honor to deal with Professor Michel Coleman, Professor Andrea Micheli, and Dr. Riccardo Capocaccia, which are the leaders of one of the most prominent projects and studies in Europe, leading Concord study, EuroChip projects, and EuroCare projects. Data were collected by the means of the 2 questionnaires, a questionnaire of cancer screening and a questionnaire of systems of cancer care. Both have been developed based on the advice provided by our collaborating partners and also based on the evidence of the best practice from the literature reviews, and also in particular on our own experience in collecting health system characteristics information. All these questionnaires have been followed up by the series of interviews with the national policy and data experts And each interview has been prepared in a very careful way. This included the complete review of the country's response, identification of those topics that were worthwhile for the further discussion, and the preparation of the supplementary questions that have been supplied at least a couple of days prior to the interview. This proved to be a valuable source of information. Opportunity to speak with someone who has a broad knowledge in terms of the policy, clinical matters, even the data characteristics, proved to be much valuable to fill some of the information gaps. Cancer survival data have been collected through different sources. The Eurocare study kindly supplied the cancer survival data for the periods from the year 2000 to 2002. The US data were obtained through the US's Surveillance Epidemiology and End Result Program, and the rest of the data have been obtained through our own data connection or through the Cancer Data Experts Network. We've been considering several methods, but we opted for the fractional polynomials method at the end because that method has a number of advantages in comparison to the standard regression methods. Best of all, this methodological approach can fit various non-linear models that proved to be quite essential to produce some of the robust results. Apart from the main sample of the countries who were able to supply complete information in terms of the explanatory variables and outcome measures, we were able to analyze the data by splitting the countries into two different groups according to their income level. And also we were able to identify the changes over time because we had an opportunity to analyze the data based on the two different periods of time. So, I'm just going to present you some of the key findings, being aware that we have some time limitations here. So, let's start with funding. We know that country's income is one of the things that really matters. This is according to the number of studies that have been published recently. Most notable, Dr. Vedekya and his colleagues published a study that identified that the country's income is one of the most important things. We have also found that the total national expenditure of health is a very strong predictor of cancer survival across all cancer sites that we have investigated. So we opted for the national expenditure on health as a more specific expenditure measure, and especially because it really was the more robust predictor in the case of the countries with the lower GDP levels. This is how the fractional polynomial look like. And as you note, this is not a linear trend. And the shaded area is at 95% confidence limit. And you can spot that there are some outliers on the both positive performance and less positive performance side. We did our best to collect some cancer-specific expenditure data, but unfortunately the response was quite patchy. Only 1/3 of the countries were able to supply some cancer expenditure data. So we even couldn't collect the data at the overall level or the cancer site level. It was even more trickier to collect the data on the cancer expenditure for prevention or screening or the drug use. So we opted to leave that explanatory variable out of the analysis at the end stage. Additional problem was huge variation in timeliness and availability of these data, and you will probably notice that the timeliness varies from the year 2001 to 2009. So just please keep in mind that information is not available at the moment. Of course, the investment in innovative cancer drugs appears to be a very strong predictor of the cancer survival. And it didn't surprise us that there was a strong correlation between the clinical use of innovative cancer drugs and the survival, especially in those countries that have a lower GDP level. Also, it appeared that the availability of the cancer drugs were much more important explanatory variable than the provision of the drugs free of charge.
Could you use this?
Okay. Can you hear me now? Never mind, I'll use the microphone and I'll keep close to them. This slide shows the year of authorization for the 10 selected drugs, and you'll probably notice that there is a huge variation across the countries. Some countries like United States, Switzerland, Sweden, and France have introduced these drugs very early. But some countries, developed countries like Norway and Japan, were quite slow in introduction. The investment in technology presented here as the number of CT scanners divided by the GDP was also closely correlated with the cancer survival in all countries. Also, we found that the human and infrastructure resources were strongly correlated with survival, especially in the case of the countries with the lower GDP level. Here is just an example. These are the number of CT scanners per million population across the countries, and they will probably spot that Japan has 25 times more CT scanners than Mexico at the bottom. So when we combined all these key characteristics of the resources, we have found that by financing investment in the cancer innovative drugs and technology and human and infrastructure resources actually could explain almost half of differences in the cancer survival. This appears to be the most significant broader domain group in comparison to the others. So these things really matter. In terms of the process quality and delivery, we have been using screening program characteristics to find out how we can actually analyze the impact of the screening programs on the survival outcome. We have been using the information such as access to screening tests in terms of the interval in years, target population, lower age eligibility limit, nationwide coverage, completed national rollout, and provision of the screening tests free of charge. We have found that in terms of the breast screening program, the factors that mattered most were the national rollout and the nationwide coverage, and to a lesser extent screening intervals. It's really interesting that the national rollout was the most robust explanatory variable in terms of the effectiveness of the cervical screening program too. By analyzing the access to services, we were able to use both referral and the waiting time. Referral time is the time from the primary health care to the secondary health care, and waiting time is the time from diagnosis to the initial treatment. And we have found that in particular, waiting time below 30 days appears to be a very robust predictor of the survival with significant test statistics, especially for breast and colorectal cancers. Here is an example. These are the average waiting times across the countries, and you will probably spot that it took only up to 4 days in Iceland from diagnosis to the initial treatment. The similar waiting times were in Luxembourg and Germany. On the other slide, the patients in Slovenia waited up to 6 months for their initial treatment. The provision of optimal treatment was also a very robust explanatory variable. When I say optimal treatment, I mean it's combined surgical treatment, chemotherapy, and the radiotherapy in those cases that have been detected in an early localized stage. The provision of the optimal treatment was strongly associated with the survival outcome, and it was more notable in the case of the countries with the lower GDP levels. So this is the summary in terms of the process quality. When we combined all these explanatory variables, we were able actually to explain up to 1/3 of the differences in the cancer survival. Finally, governance. As you may note, the majority of countries haven't introduced their national cancer screening programs before the year 2002. There were just a few of them that had the strategies and the plans at that stage. So instead of using the national cancer control programs, we actually estimated the impact of the certain characteristics that were implemented within the national cancer strategies. And we have found that the following characteristics of the national cancer policies were the most robust predictors of the cancer survival. These were fully implemented national cancer control plan, or setting up the cancer-specific targets or objectives, assigning the lead person or organization to oversee the implementation, identifying the key milestones and timeframes, monitoring the process, implementing the guidelines, introducing the case management and the coordination of the cancer care, and ensuring that the quality assurance mechanisms were put in place. These were the key characteristics. So even in those countries that haven't introduced the national cancer control plans, if they had these characteristics in their strategies, they proved to provide the more coordinated and the better care. What's also interesting that we were able to analyze the data and to compare results between two different study periods. And we have found that during the initial phase, the most important characteristics were to set some targets and the time frames, to monitor the progress, to ensure that the guidelines and the quality control are put in place. In the later, more mature phase, the fully implemented National Cancer Control Plan assigned linked person or organization, someone made responsible to achieve the targets and to ensure coordinated care were the elements that actually proved to be more effective. So when we combined all these explanatory variables, we have found that according to the results of our modeling, approximately 1/4 of differences in cancer survival could be explained by the characteristics of the good governance. So this slide summarizes these findings. Please note, still it's very important how much money you spend, how much you invest in the drugs and the technology, how many oncologists and the cancer comprehensive treatment centers you have. This is still the most relevant factor. It really matters also how you provide the quality of care, how easy is the access, how good is the quality and comprehensive quality of care that was provided. Unfortunately, we were not able to find out what was the level of compliance with the clinical guidelines because that information is scarcely published. But according to the anecdotal evidence provided by the cancer experts, this proved to be probably another element within this particular dimension that should be taken into the account. And please note, governance and the organization of the cancer care play quite significant part as well. It was quite tempting to use all these variables that have been identified as the robust predictors of the survival to calculate so-called predicted cancer survival rate. And we did it based on the existing fractional polynomial models. We got some predictions and we were able to compare the actual cancer survival against the predicted one. This slide shows these differences for the cervical cancer, and you will probably spot that at the top we have countries like Korea, Canada, and on the bottom Czech Republic and Hungary. So this came as a little bit surprise. You would never expect these data that way. So how we can explain this? Yes, we can provide more insight if you look at the data and the differences across these key elements. And I'll use the example of comparison between the Czech Republic and the Korea to clearly demonstrate this. So what's the difference between these two countries? They have quite similar characteristics apart from those ones that are shown on this slide. So Korea has a higher GDP, but had a lower total national expenditure on health per capita than Czech Republic. They have much more investment in the technology, but they have a lesser number of comprehensive treatment centers per capita. They have the higher rate of the provision of the optimal treatment, but the most notable difference is actually in terms of the governance and policy, because Korea introduced their national cancer control plan in the mid-90s. They set some targets, they set some time frames, they took it quite seriously and they monitored the progress. So according to these characteristics, these are blue highlighted are the predicted values, 63 and 69%. But the actual difference is 57 versus 75. 5% more than predicted in the case of Korea, 5% less in the case of the Czech Republic. When we analyze all these differences between the actual and the predicted values, we have found that those countries that have been overperforming in comparison to their characteristics achieved that focusing mainly on the good governance and the resource input. And those so-called underperforming countries exhibit issues evenly in the areas of the governance and the process quality. It really appears that it's a governance and the policy that is of relevance for all countries. So instead of the conclusions, just a couple of closing remarks. These results shed more light on the underlying features of the cancer care system, especially which policies actually matter and which are the elements within these broad domain groups that appear to be particularly important. Yes, we know that wealth is still the factor that matters, that makes the difference between the countries. But also we know that the level of health investment, especially in the case of the countries with the lower income levels, actually show that when you increase the investment, you reach a certain plateau, and the better outcomes can't be achieved easily, one that a reasonable resources level has been already reached. We also found that the richer, better performing countries achieved that by establishing the cancer quality priorities, implemented key elements of the cancer control, they introduced the integrated care process, and they actively work on the delivery of cancer services. This proved to be the pattern across all those countries that have been identified overperforming in comparison to their characteristics of the cancer care system. Of course, this study has its weaknesses as well, that actually set some agenda for getting better information in the future. Firstly, we need more up-to-date cancer survival data. Please note that we have been using the cancer survival data for the period from 2000 to 2004 and later on up to the year 2004. So what we found is that during the last data collection that approximately three-thirds of the countries were able to provide the period survival estimates. And the period survival estimates have significant advantages in comparison to the standard cohort ones because it doesn't take 5 years to pick up the advancements in terms of the earlier detection or more effective treatment. It takes only 1 or 2 years to get to the first signs that some improvements have been made in the most recent period of time. We also need the staging information. Staging information is critical because without stage information you can't distinguish between pre-diagnostic and post-diagnostic factors. You don't know how well you are doing in terms of the early detection or how effective is your treatment unless you adjust the data on the stage information. And according to the latest feedback that we got to the data collection, it appeared that there is a quite significant number of countries, up to 15, that could supply very specific information on the stage. Also, we need more specific information on the waiting times, the level of compliance with the guidelines, cancer-specific expenditures, and information about some newly introduced screening programs like a colorectal one. So, instead of the final conclusions, just information that we'll be sharing the results of this study over the next couple of months. We'll be seeking the feedback from all these countries that have participated in the analysis, and we are hopeful that we'll release the final report by November this year. So, thank you, Madam Chair.
Thank you very much.